Hello and welcome to episode 11 of Auditing Antics Podcast. So today we're going to be breaking down critical care, and this is a particular area that can be very painful. And, Michelle and I both are aware of the fact that, when you're working internally in an organization, this is an area where there's a lot of pressures coming in from the clinical perspective as well as administration, looking at the financial side of things. And it doesn't always crosswalk and pair with what we need to be aware of and do from a coding perspective. So today we're going to break down a lot of that and hopefully provide you with some clarity as what you can use to go back and have, constructive conversations related to this subject and really focus on making sure that everybody understands the risk that's out there if things are just constantly defaulted, and making sure that you have the framework to have those discussions and hopefully institute change in your organization. Now, before we dive in, it's going to be important to also recognize the fact that when we talk today, we are talking from the perspective of the coding guidelines and what this all means from a documentation perspective. I say that because critical care can be one of those sensitive type areas where, the providers we're working with, the physicians, the practitioners, they have their thoughts clinically. And like I said, it doesn't always cross into coding guidelines. So sometimes people will misspeak, for example, and
Mhm.
say, oh, this isn't critical care. You weren't caring for that patient critically, or, those types of things. And I don't want anything we say today to be misconstrued in that way, because we are strictly speaking from coding guidelines, what that looks from a documentation standpoint. I will say that clinically, no, not everything is going to come into this across the board. Things like the specialty of the provider who sees the
Mhm.
patient, the unit or patient setting that they're in, especially if it's, a critical unit, the diagnosis of the patient. None of those things automatically dictate and have inherent medical necessity across an entire hospital stay. So
Mhm.
again, drilling down to guidelines, making sure we understand that a critical provider, even if we're dealing with an intensivist, is not going to have critical care from the beginning to the end if the patient is hopefully improving and being discharged and all of those things.
Yeah, and I definitely would recommend if you're finding yourself having these conversations or needing to have these conversations with your provider, just kind of start it off with that little caveat that you're not you're not there to tell them how to do their job or whether their patient was severe enough. You're just there to talk about what ended up in the documentation and what that is showing of the care that they provided. And I think a lot of times that kind of helps buffer some of that conversation and some of that standoffish kind of attitude that we can sometimes experience, because when it comes down to it, I don't know if any of you watching this have ever shadowed in an ICU or had a loved one in the ICU, or anybody, you know, been present for care that would qualify as critical care. But you can definitely know that they are doing the work. It's just we have to we have to bridge that gap between the work that they're doing and what's ending up in their documentation. And so I think if you start off the conversation like that and make sure that before you go into those conversations, you're being mindful of the wording that you're using, and just present it from the perspective of coders and auditors are not allowed to look at something from a clinical perspective. And that's why Stephanie was saying a specific diagnosis or certain lab values or different things like that can't just automatically support critical care. The provider has to convey that in their documentation.
Yeah. And, that's one of the things too. I've joked in the past that, We've probably all had the coworker that you hear on a phone call or a meeting, and they're telling the provider, what you did isn't critical, or using language like that. That's something that can be really damaging, especially in the relationship you're trying to, hopefully form with the practices and the individual practitioners you're working with. So just tread lightly in that way, making sure that it's known that there are, different perspectives that have to be followed with this.
Mhm.
Now, when it comes to the guidelines themselves, one of the things that I find when I'm reviewing charts and don't necessarily agree with what I'm seeing documented as critical care, there's issues because there, for example, could be one component. Like in the ER, that particular setting, yes, it's difficult. There's always back and forth, differing opinions in this area. But one thing I find is that sometimes, based on the diagnosis, for example, they'll automatically say that it's critical care.
Mhm.
And, it's one of those things where we have to first start at the guidelines and recognize the fact that what we're dealing with is situations, whether it be injuries, illnesses, whatever symptoms are coming about. It has to be something that has that high probability of imminent threat to life or organ function in the moment. So it's not one of those things where it could eventually happen because of
Mhm.
the injury that occurred. One of the things I think of, I've spent a lot of time reviewing ER records, and you may have a patient, for example, who's been hit by a vehicle. Some of them have an X-ray, they're cleared, everything's okay, and they leave. Some of
Mhm.
them are so bad off that they have emergency intervention, emergency surgery to stabilize that patient, and the probability of life and death is unknown at that time. I'm not
Mhm.
saying it has to be at that extreme, but this is an example of where we can't just assume based on, that presenting problem that we're automatically in critical care.
I think, just real quick, Stephanie, something that just popped into my mind is the word protocol. Just because something is a hospital protocol doesn't mean that that's going to fit the criteria for critical care. So there may be certain things that, this particular type of injury is coming into the ER, there may be hospital protocols of what steps need to be taken and the things that need to be done in those certain situations. Like you said, some may result in critical care, some may not. So don't mistake protocol for medical necessity for critical care either.
Same thing with clinically. I know we've talked some recently, Michelle, in different audit reviews about what that looks like if there is, do you remember the name of it? I'm completely forgetting right now. I think it's in the ER. So when you have a patient come in, it's concerning as to whether or not, it is going to be a critical situation. And I always refer to as an event, but there is a specific clinical term for it, where they're calling in that team to assess the patient to
Like a
see,
trauma
okay,
alert.
exactly. Yeah,
Hmm.
that's a good way to say it. Um, and, sometimes that is taking place, at least from what we're reading inside of the notes, it's taking place when the patient's first, being transferred or
Hmm.
transported into the ER. So they don't know yet what that patient's like when they get there. And one of the things that we have to remember is we have to take everything into consideration. So it's not just that it is some kind of alert. It's what,
Hmm.
okay, how is the patient? I have some, for example, as well, where I'll read it, and yes, the situation looked really bad, but by the time, especially with overdoses, for example, by the time the patient gets into the ER, they're stable. Everything within the examination is showing that there's no current concern for the patient. They're being monitored to see if additional treatment is needed. And then in the end, it turns out it's not. So they're monitored and then they're released from the ER. Now in the field, when the EMS team got there, yes, that patient was not conscious. That patient required Narcan, all of these different things. But we have to remember that we're billing for the work of the practitioner or the collective team that we're reviewing. And we have to consider that. It's about the here and now. When it says that imminent threat, it's that immediate threat to that patient. I do find that the events that occur that require that rapid response are much easier to identify. But, obviously, if that patient's hospitalized, things like that, we're going to have day to day decisions we have to make about critical care based on the notes.
Yeah. I recently have found myself in this loop of critical care audits. So I feel like I've been in the trenches of critical care auditing and seeing all of these different scenarios. And when I'm doing audits, I like to do some research to find some verbiage and wording to use in my comments. And I came across um, C CGS. I don't know why I almost said a different one, but an overview and a definition that they used for critical care. And I really like how they define this. So I'm going to share that with you. They defined it as critical care services requiring direct personal management by the physician or provider. They are life and organ supporting interventions that require frequent personal assessment and manipulation by the provider. Withdrawal of or failure to initiate these interventions on an urgent basis would likely result in sudden, clinically significant, or life threatening deterioration in a patient's condition. I really like how they worded that. The life and organ supporting interventions, I think that is something that is key. And when we're talking about documentation needs to convey the critical scenario, and that it's not just the name of a diagnosis, it's what is the diagnosis along with what are the life and organ supporting interventions that the provider is doing on this date for this patient. And I also can remember early on, Stephanie. So, my first ever coding job was coding the professional hospital E&M encounters. And I mean, newly certified in their coding. And I'm like, oh my gosh. So, you and I were having a conversation, and I remember very distinctly when I was like, well, how do you know? Like, how do you tell the difference between high complexity and critical care? And the one thing that has always stood out to me that you specifically said to me is, what would happen if they stopped all the treatments right now? And, if the answer is the patient would pretty much immediately have a crisis, then that's your answer. So we're looking for that. I don't want to use the word urgent. I know that it's not always an emergency. Like you said, those are
Well, just
much
interventions or,
easier to identify, but
yeah.
it's really what are they doing to support that vital organ failure that they are supposed to be documenting as well.
Well, one thing a lot of people forget about is the fact that when we look even at the AMA level at our definition of critical care in the guidelines, it speaks to not just that part. Again, we'll link it to the presenting problem, not just a situation that requires the support, but it even goes on to say there's highly complex medical decision making taking place.
Mhm.
So that's another thing, when we're reviewing that scenario in an ER where yes, it could be based on what
Mhm.
occurred, depending on the patient and scenario, it could be a critical situation. But did you have highly complex? And, if we're looking at monitoring just from that perspective of not even necessarily running a lot of tests, sometimes it's the visual monitoring, the examination of the patient. How do we argue that that's going to be highly complex medical decision making?
Mhm.
And I think it's important to understand as well, which again, there's going to be so much subjectivity around this topic, right? Because it's just one of those things where even when we look to AMA, when we look at our MDM grid, We know we have that third element that represents risk of treatment, but we just have examples and they're not all
Mhm.
encompassing. So
Yeah.
we have to think to that. And, sometimes for me, I have to have conversations with the treating practitioner during an education session so that
Mhm.
I can better understand what it is they're doing if I can't see it in documentation. And to your point, like you said, we in these purposes, we are auditing for documentation and coding. We are not clinical auditors. That's a completely different process somebody would go through with a different
Mhm.
department. And sometimes it takes having conversations to understand, okay, what is this? Why, if that is your treatment, and to me, the layperson, I don't understand why it's clinical. Can you explain to me, how this is supporting a system or monitoring that patient closely for that
Mhm.
deterioration?
Yeah, and I think that's what's important to help get across what we need to see in their documentation. Um, we just need to know the why. You got to tell us why you're doing these things in addition to what you're doing. And a lot of times we just have a list of what they're doing. We don't have the why are we doing this? Is it specific things about the patient's condition that's giving you concern and things like that? Um, so just make sure that the providers are understanding. Give us your thought process. And one thing that I also wanted to say, Stephanie, that you had mentioned the table of risk on, the having the different levels of complexity. Sometimes we have to kind of look at these situations as out of the box. And like you said, when we have conversations with a provider, sometimes the medication management is going to be what's preventing that, that imminent life threatening deterioration. So we kind of also have to be willing to think outside of the box and not try to place these interventions into these different, categories on the table of risk, because when you think about it, other than them saying high complexity medical decision making, that that's going to look differently, I think, based on what the current situation is for that patient. And we can't just look at those examples in there and say that's the only thing that would support high complexity. I think we have to look at the overall picture of what's going on and what the provider is telling us they're doing. And sometimes we have to have those conversations to better understand that those interventions are what is basically preventing the imminent decline of the patient at that time. Um, but just something to think about as critical care relates to that table of risk.
Well, and this whole subject reminds me of a project I worked years ago. I was basically the third objective outside party between a hospital system, it was their ER department, and a payer, a very large payer. They could not come to an agreement. So,
Mhm.
due to that, they agreed to hire an objective third party, bring them in, have them review. Now, this was related to high complexity level 5 ER services, but the same concept applies here where we have a lot of subjectivity. And it could be something, we talk a lot about how, not every chest pain is a 5, not every
Mhm.
abdominal pain is a 5. It's the same concept with critical care. And one of the things I found interesting, there was someone who came to the review of findings from the payer side that was a physician. And, we have different opinions on that. I know that I've spoken about it before on Sean Weiss's podcast too with Compliance Guy. And in the work that we do, it can be frustrating because sometimes when clinical is brought into these conversations, they're not always of the same specialty of the practitioner.
Mhm.
So that particular part was frustrating because it was an OBGYN physician telling an entire ER department that the majority of, items are not a level 5 or high risk. But one thing I took away from that was the fact that the lack of detail from the treating practitioner really played into that entire situation that that hospital system got themselves into. Because when we are looking at this from a non-clinical perspective, the way to lessen the subjectivity is to have more detail related to the thought process of the practitioner. So
Mhm.
if you're saying that, that patient was, coded in the field, then they get there and they're stable in the ER. Okay, yes, they're stable, but what are you thinking through? What is your concern for this patient? What are the organ systems you're having to monitor? Not saying that that will automatically get us to critical care, because it doesn't
Mhm.
even automatically get us to high risk, but it plays a really large role in critical care because every day has to stand alone. And, when we get into the hospital setting, it makes it that much more difficult. Again, the first day, the rapid events, those are much easier for a reviewer to see. But as we go through subsequent day to subsequent day, we get into a lot of bad habits in
Mhm.
documentation. A lot of the smart tools are not used accurately, and it gets more difficult to defend with a lack of detail being added.
Yeah, definitely have seen some of those, like you said, we'll call them bad habits. Um, some I'm going to kind of transition us to some of the things to, as you're coding these, say you work for a hospital system and it is your role to code for these critical care encounters. There's some things that we as coders are able to identify as issues, and we need to bring to the appropriate people to make sure that our providers are getting the appropriate education so that we can support and bill for the services that they are providing. I think a lot of times people don't like to rock the boat. They don't like to identify potential issues um, because maybe it hasn't been well received in the past. But we have to bring these to the forefront because at the end of the day, we're all on the same team. We all work for the same organization. If we can't bill for the services we provide, that's going to pose an issue down down the road. And it's not them, you against them or anything like that. It's literally we're all part of the same team. If you see something, you should say something so that it can be educated and and an error be fixed, or a workflow might need to be changed, things like that. So some of these things that you can really easily pick up on if you are pretty consistently reviewing services, especially like I said, in my earlier days, I was coding for those professional inpatients. A lot of times I was seeing day after day after day for the same patient. So, one of the issues that's really easy to identify is how is the provider documenting their time? Are they putting 30 minutes on every single critical care time statement just because they know that meets the threshold and that checks that box? Are they documenting the same time for literally every single patient? 30 minutes may not end up representing the impossible day, but it could call into question the validity of the time because each individual patient is unique and each problem that they're going to be addressing is unique. And most likely, every patient isn't only going to be taking up 30 minutes of that provider's time. Especially for critical care services. So, you want to kind of pay attention to that and give appropriate education about billing based on your actual time spent. And it's not just we have to meet this threshold. I know I spent at least 30 minutes, that could be what the provider's thinking. So I'm safe putting that on there. That is definitely something that could be picked up as a pattern from an outside auditor and could call into question the validity of that time statement because they all just start to look the same. And it's like every patient isn't the same. Another issue that I know people run into is being told to just bill critical care because the provider is telling you it's critical care and you need to bill it as such. I mean, this could be, I don't know about you, Stephanie, but I definitely have experienced pressure from either the providers themselves, like I am, you know, a critical care provider. I think I would know if this was critical care if I'm sending it through as such it is. Or even from administration, I know there has been situations where critical care has been being billed, and when issues are identified, the response they're getting is, well, that provider's not really easy to talk to. They're not really open to conversations about how their documentation doesn't support critical care. So we just send it through. And that definitely isn't a good policy to
No,
adopt.
no.
You have to have those difficult conversations, because as the person submitting it, knowing that it's not supported, you also have have a play in that incorrect
Exactly.
billing for those services. So there are times when you as the coder has to say, I am not comfortable with that being the resolution. We have to come up with a different answer. And I know, you know, Stephanie, we had talked about creating internal policies and having a really good solid internal policy about critical care that when you have these situations, you can take to those providers or to administration and use that as a tool to back up your findings and the need for education and the need for accountability in that areas. A lot of times we're not going to be the ones that provide the accountability in these situations because we're the bad guy in their minds going in, just like you said, saying this isn't critical care. You don't provide, you know, serious, you don't take care of serious illnesses, you know, making it sound like we're downplaying the severity of the patient.
Mhm.
So you need a way to make this official and to show the issues with not complying to the policy. I don't know if you have anything to add to
Yeah.
that policy.
So, one of the things, and I put a comment up here from Kimberly Smith, she said, "You're making very important points that many organizations do not understand or agree to." And I think we need to talk about this for a little bit because this is something where when I come in to do reviews, sometimes I get pushback from a
Mhm,
compliance department, coding management, definitely from the providers themselves. But this is really concerning because a lot of people look at it from the perspective of, well, we have to give them a break on the administrative side. So we
mhm.
allow overuse of copy and paste.
Yes.
How many times, and let me call to light again, I had mentioned that this becomes more complicated when we look at subsequent visits. So a lot of times what we're dealing with is, yes, the patient is improving, but we have to see the continued level of support and what the specific interventions are. And, there's times where we'll do an internal review and we're going to call that out and say, hey, you said that this patient's doing well. They were sitting on the side of the bed. They were walking around. They were up and eating. Okay, that's fine depending on what's happening. And I've had some physicians get upset and say, well, am I never allowed to say that the patient's improving? And I even had one go back to an entire department of intensivists and say that they're not allowed to use the word stable and improving. But that's problematic because number one, compliance rules are not here. We're not here to dictate what they're doing clinically. They
Mhm,
still need the ability and the autonomy to document what's happening clinically. We have to understand that on our side as well when we're having these discussions, that that's a part of getting everybody on the same page.
mhm,
So while a patient could be improving, or we'll often see in a note that they're hemodynamically stable. I've had many conversations with intensivists talking about the fact that, yes, that particular system or, that component for the patient is stable, but it doesn't mean that everything is stable and that we're not having to intervene because they're stable hemodynamically. So,
mhm,
again, we've got to understand, but let's talk some about organizations that allow the bad habits, now by bad habits, what I mean is the use of the EMR smart tools. This is
Yes.
something I've been so frustrated with because I don't understand how, when an EMR system, especially large ones, implement these tools, they just put it in there and say, oh, this will help you administratively. They don't listen to everybody else in compliance over here saying you've now created issues.
Hmm.
And one of the things that I find, and I know you just had this recently, is that when the providers are overusing copy and paste, it's getting to the point where everything's being brought forward and maybe they're changing a date or maybe they're changing
Hmm.
the number of minutes, but everything else is staying exactly the same.
Yeah. And one thing that I like to call out in those situations, so now I primarily do external audits. So I'm that external person coming in to look at the documentation, and we do run into a lot where clients will get their audit results back and they're like, well, this isn't right, this should be allowed. We allow these different things, and it's it's not correct, and they'll be like, we have an internal policy that says this. So one thing to keep in mind is if you're having an external review, it's not just to look at the accuracy rate of your providers or your coders. It's an opportunity to look at the accuracy of your policies and the effectiveness of your policies in your compliance program. So if you're having an external reviewer come in and they're giving you, you know, good, valid, solid feedback, I think Stephanie and I can both agree that sometimes it's just way out there. From an internal perspective, you're like, what? This is way in left field. There are going to be those situations, but take that time to kind of evaluate what you're disagreeing with and where your thought process is coming from versus where that external auditor's thought process is coming from. It will really help you to understand, maybe there's somewhere in the middle that you can meet, or maybe there is a change that needs to be made to your internal policy. But I kind of got sidetracked there. Um, now I forget where I was originally going with that. But back to different issues that we're seeing. You
Mhm.
had mentioned the use of copy and paste. I think that's where I was at. Got to get off my soapbox there. But what I like to do when I am seeing excessive use of copy and paste is take a look at what's being copied forward, and is it redundant? How many days has this note been copied forward from? How many different providers have copied this note forward? And what is the actual information that they're copying forward and essentially saying is today's work? Because that's essentially what they're doing. They're By copying that forward, they're saying this is my work from today. And a lot of times when it comes to copy and paste, you can see the inconsistencies and the redundancies in the documentation where this really doesn't represent work of today's encounter. A lot of times, especially where critical care is involved, there's conversations and discussions that are being had. And when we look at the nature of these discussions, it's unlikely that you're having the same exact conversation day after day after day with the family members or other providers, or re-reviewing the same imaging day after day after day and having that be part of your treatment decisions for that particular day. So I think a lot of times,
With no
yeah,
new data, right?
with
Yeah.
with no new
Just
data, like,
looking at the
they'll
older
say
stuff, not
it's
comparing or
an MRI from 3 days ago that for the past 3 days, you have documented through copied information saying that you have reviewed that for the past 3 days. How Tell me how that is relevant to your treatment decisions you've made today. So sometimes that kinda helps to view the overuse of copy and paste in a different light, is when you point out the redundancies and how things may not actually represent accurate information. A lot of times this can lead to overcoding of an encounter. I know some of the rebuttals that we get back when I go in and I look at these things, come to find out it's actually been copied forward. And that's why I wasn't considering that when I was determining the overall level that was supported, whereas the person who is in the organization wasn't looking at that from a copy and paste perspective. So you got to keep those things in mind, with especially with that overuse of copy and paste. We want to make sure, especially for services like critical care, that your note stands on its own. How is today's encounter uniquely critical care, even when there isn't a change from the day prior? Stephanie, how do you tend to approach that with providers when they say, well, nothing has really changed from day to day, but the patient is still in a critical condition? What do you how do you approach that kind of situation when you're educating providers?
So for me, it all comes down to free texted documentation. Because if we have overuse of macro statements, overuse of templates, all of those types of things, we're not going to see these individual components. And, if we think back to what we said about patients requiring life support, organ support, highly complex medical decisions that are being made, how does pointing and clicking some orders or things like that show us that day in and day out consistently that patient is still in that state?
Mhm.
And, one of the things that I have the most concern about when I'm working with these different organizations is when they allow the practitioners to have their critical care statement be only based on time. So, what I mean by that is the average person, and especially people who misunderstand critical care, will think that reading a macro statement that says, today I have spent 30 minutes personally in critical care services. There's variations to that, but the overall gist is just that. They provided critical care with no detail as to what it was, and they gave us the number of minutes.
Mhm.
That is a huge misconception and misunderstanding because that is not what we're supporting it on. And it goes back to everything that we do in our industry where we have to have supporting medical necessity. So just saying critical care, not enough. I see that statement. Okay, great, you met a time threshold, but that's not what I'm saying as an auditor and reviewer
Mhm.
supports critical care. And, I've had situations, for example, when I'm working with where I'm, for example, the outside auditor working with a hospital system, but they have external coders. And the external coders have maybe nursing background. So they're
Mhm.
heavy clinical, little knowledge on the compliance and coding side. There will be arguments there back and forth or um, disagreements because they're looking at, different values coming from different devices that are monitoring a patient or things like that. But we have to remember we can't apply any clinical knowledge. We're not clinicians. Even if you have that background in training, that's not what a documentation and coding audit is for.
Mhm.
So, with that being said, when we look into the note, one of the things that I pick apart first is the interval history in the HPI, because we want to know from the provider's perspective when they're talking to maybe family members, friends, whoever's there with the patient potentially. We want to know from the perspective of clinical staff that are treating that patient day in and day out, doing monitoring, different things like that. We want to know what the thought is there. So when we see from that perspective, the patient's doing well, they're stable, no new complaints, then we've got to go to the next sections to begin to, dissect down and say, okay, overall, what does this note show us for the day?
Mhm.
When we get to the physical exam, to your point, where sometimes they'll say, patient sitting up, eating meals okay, Another one that comes up often is when a patient was previously on ventilation and they've been weaned off of that, so they're now on room air. All of those types of things are showing improvement. The care has been discontinued. That was the main intervention for the patient. Then we get down into the assessment and plan. What happens if it's all copied and brought forward?
Yeah.
And maybe that doesn't match the fact that they're now no longer on ventilation or whatever that intervention may be. So then we have contradictions.
Mhm.
Or the other side of that is sometimes we get down into the treatment. It says patient doing well. We're coordinating, getting ready to transfer the patient to the other medical unit that day. Again, a sign of de-escalating care. At those times, from a coding perspective, that's showing us, okay, this is no longer meeting the definition of critical care. So, I say all of that to just point out that all of those sections matter.
Mhm.
And when I've had to help organizations who are going through external audits with payers or investigations with payers related to critical services, or like I said, we can apply this to highly complex services with level fives or level threes in the hospital.
Mhm.
When I'm working through that, the external reviewers are dissecting apart in this way. They also do not care that the note only says 30 minutes were spent of critical care
Mhm.
services, personally by me or whatever it may be. They're
Yeah.
going in their findings and they're saying, well, you said they're stable here. You're showing this here. So, to your point, Michelle, this is a large part of education and going back and having these
Mhm.
conversations is taking a patient and looking at a whole hospital stay and saying, okay, what overall was going on with this patient, and then showing how the documentation is, you know, pointing more towards the other services.
Mhm.
Now, with that being said, a couple other scenarios we need to talk about is situations when we have residents involved in teaching facilities, and also we have a lot from the split shared perspective as well in the
Yes.
hospital. Now, one other thing, well, actually, I'll talk about that after because I want to talk some about the statement and what that should look like and what people can do to, improve that in the organization. But
Mhm.
let's talk first with residents. So, this is something we've got a time-based service. Residents cannot on their own render and bill for a time-based service. So the question is at that point, what does this mean for our teaching physicians? And, Michelle, one of the things I struggle with this is that organizations, again, will allow their teaching physicians, so their faculty, to state, I've spent 30 minutes of critical care, but yet they're referring into a residence note, which in a normal situation outside of critical care would be fine,
Mhm.
but it's sending mixed messages that that time was not personal of that faculty member, that teaching physician.
Yeah. Are they trying to bill for that time spent by the resident? Definitely something that I come across all the time, just because of even things like the use of a macro statement and having that available. While those are really useful tools and ways to help speed up areas of documentation, they really aren't intended to completely replace the need for that documentation or that free text of what was your personal critical care work on that day. Because when we see those statements where we see an entire critical care note documented by a resident, and then all we see is, I saw and examined the patient on this day, agree with the, assessment and plan for from as documented by the resident, I spent 30 minutes of critical care time on this date. That doesn't tell us what they personally did. It shows us what the resident did, but what did you, as the physician, how did you personally render critical care services? And I think you can agree, Stephanie, it doesn't have to be this big long note, but include, what organ systems were you supporting and what interventions we're done on that date. And I feel like that can be accomplished with a pretty brief synopsis of how you personally provided critical care on that day.
Again, going back to highly complex decisions that are being made.
Yes.
And, I do find too that sometimes when residents are involved, they're the ones documenting critical care time as well,
Mhm.
because there's a misunderstanding in that organization that, the time has to be documented by the physician because it's their personal work. Now,
Mhm.
I will say when it is more clear when a resident's involved is when we have those rapid events, because a caveat to all of this is that if the physician, the teaching physician, is physically at the side of the resident during the time, then that can be noted and counted as well. But the majority of the time, what we do have happening in workflow is the physician seeing the patient separate from
Mhm.
the residents just on the same date of the encounter.
Mhm.
Now, with critical care, this is another area we have to be aware of the fact that we have time based services for the most part, unless you're billing for pediatrics, which are the per diem codes or per day codes. And, when it comes to the time based critical care codes, split shared services are also an issue because we have that scenario where the physician is wanting that APP practitioner to document for them. A
Mhm.
lot of times in workflow, they're looking at that as, help on the administrative side, also on the clinical side, with them providing care collectively with the physician. And, this is something we could talk about forever because split shared, it has its own issues. But I've had some questions this week actually from some of my members writing in and saying, hey, what do I do when the physician wants to bill split shared, but they're saying in their note, or 60 minutes spent today, I spent the majority of the time. So we have a situation where each provider is not documenting their own personal
Mhm.
time, and still we can't see the work of that physician who's wanting to bill supposedly for all these decisions they're making. But in documentation, it looks as if the APP is doing everything.
Yeah.
So that's really challenging too from a review perspective, but a process improvement perspective where you have to stand firm. You can't just continually let these things go through because you have to remember your name is on this as well.
Mhm.
So, especially if you're working in, epic work queues, for example, how many times have we heard in training, we both work external where we do internal reviews for organizations, but we're not employed by them. So
Yes.
we're coming in externally to work with these hospital systems, and we've gone through different epic trainings and things like that. They'll say things like stay in your lane, address only what the edit says, push the claim out.
Mhm.
Absolutely not. We
No.
have to remember that it's our responsibility to pay attention to compliance. We have our own responsibilities based on our profession, our credentials, our professional ethics, hopefully personally and, through AAPC, AHIMA, different organizations like that. So we have to make sure that if this is a problem on a large level, you are being a part of the solution and not just blindly following and
Mhm.
pushing out because of all of these pressures, which
Yes.
can get stressful. Now, there are things that you can do to, to really go back and show your point of view. So, what I mean by that, and we both had a situation recently, our sister in law is a coder and auditor, and she had a scenario where she was identifying a lot of issues and the
Mhm.
organization didn't want to address it. There's one particular person in administration constantly pushing back, again, for whatever reason. Maybe she just doesn't want to deal with it or whatever. But she knew she was right. She knew that the claims going out in that way would be incorrect. And, she went back with resources and said,
Mhm.
look at, you're verbally telling me these things right here from CMS or right here from, claims processing manual, the MAC in your state. the commercial payer policy. In writing, this is why we can't take these steps. This is why
Mhm.
we can't go through this. And these conversations need to happen more. You know, we have here Pam Vanderbilt put a comment here that part of the reason critical care is so challenging is because clinical language is so different and from place to place or place of service to place of service and different from coding language. And that's absolutely correct. And, you know, one of the things that I suggest when there's an issue like this that heavily involves compliance coding and clinical is you've got to have all of those people at the table. You
Mhm.
know, I very firmly believe that even when I find problems, I'm not going into meetings saying I'm correct, you're wrong, you know, all of these things. I want to hear what everybody else has to say as well. I want to know from that clinician, okay, what is it you're actually doing? Especially when we get into more specialized medicine, when you think about, you know, all of the areas of pediatrics that do critical care. We
Mhm.
have intensivists, but we have other specialists as well who will go into those critical units for consults and caring for other conditions. So we need to have somebody from the clinical viewpoint, the administrative, you know, when we think about that pressure financially, things like that, we need their viewpoint so they hear why this isn't just a quick decision. We
Mhm.
need compliance, we need coding. One of the things I've found over the years, which is frustrating and you know, I don't like to see it, is that sometimes this pressure and this back and forth exists between a compliance department that does not work with coding. You know, there's so many different things that can play into it, whether it's internal politics and one person thinks they're better than another, or one doesn't want to say they're wrong. It's not about being wrong or right. It's not about, you know, proving something to somebody. You have to collectively work as a team. And to
Mhm.
see that division, all you're going to do is hurt the organization. All you're going to do is increase risks if you can't come to a resolution. And you have to go through this. So,
Yes.
like you said, Michelle, administrative input is important because the decision has to be made and it has to be enforced
Yes.
without
Yep.
repercussions to people who are, you know, on the front lines needing to deal with that. And you know, if you want to end out, I think you had a really good example when you were working production coding with this, and you know, you were basically told as a resolution, okay, well, you're saying these aren't critical care, but now you're going to have to tell us every single time you
Mhm.
want to down code. And did you find that that process helped that organization work through it from all of these different viewpoints? Okay,
No.
for those listening, she's shaking her head. No.
Not at all. So, I think back to being, a little baby coder. Not only was this a terrible resolution because we had already been the punching bag of this issue. We
Yeah,
had
good point.
we had providers yelling at people in our department, those people coming and yelling at us because they just got an earful. And now we're already like, oh my goodness, this is not, this just blew up, and now those people have they weren't interested in hearing what we had to say. They didn't have any faith or trust in what we were doing. And so now you want us to send them a little in basket
Yeah.
and say, this doesn't meet critical care. Here's why. Do you think they're going to listen to us? No. So
So
I
you
think,
really didn't have that full administrative backing. They
oh
just were
no,
everybody was
no,
trying to tackle it individually.
we didn't. And I think it was trying to be tackled more so from um, we need to make these people happy. Like, holy
Yeah.
cow, they're really mad. How do we make them not mad? And, in that situation, that's not a thing, in my opinion, for the coders to necessarily step in and de-escalate or have to deal with that on a regular basis.
Or verbal
I
abuse and many
Yes,
other
I
things.
am I am one who, maybe it's just where I am at in life, but if you're going to have a conversation with me where you are yelling at me, I'm not going to entertain what you're saying. I'm going to say, I don't think we're going to get anything accomplished right now. I am going to step away. And when we're able to have a conversation, everybody deserves to be treated with respect and dignity, regardless of your position. Nobody deserves to be treated that way. A lot of times when these issues come to light, there is education needed on both sides. In that situation, I can tell you, I probably needed education for sure. I was just brand new, but also the providers needed education as well. And they need to be open to that and understand. And a lot of that comes from not not you as the coder, but from the higher ups, the people, your leadership within your department needs to get with the appropriate leadership to say, hey, we can't have these situations. I'm pretty sure you wouldn't allow somebody to walk into, we'll say, the ICU and start yelling and screaming at a doctor. So why are we allowing that to happen on the other side? That's sometimes you just need to remove. I know you said all the people need to come to the table, but sometimes there needs to be a
Leaders,
little
I
bit of
mean.
buffer. Yeah. There
Yes,
needs to
so
be a
not
little bit of a buffer
yeah,
there. And
yeah, not the
'cause
whole intensivist department, but
no,
their lead physician
the
who's a part
people.
of an administrative team.
And
Yeah,
eventually, ironically enough, down the road, as I grew as a coder and gained more experience and knowledge, I ended up having to oversee that department and was able to actually foster a really good relationship with them. And I think too sometimes it could be external things that are happening that are causing some of these reactions. And so I think empathy goes a long way to all parties involved. But I mean, I'm sure like the example you just gave with somebody bringing forward this clearly incorrect coding, and it came out that this provider isn't the easiest to talk to, and so
mhm,
we to avoid confrontation we just let it slide. That's not the answer. And if if confrontation is going to result, then you have to resolve a whole other issue separate from this compliance issue. Then it becomes this whole other separate thing that has nothing to do with compliance at all and everything to do with behavior in the workplace. And
yeah.
I think that's important to recognize from the people providing the education. One, sometimes people just have a bad day. I could not even imagine being in some of these physicians or providers' shoes, having to provide the care that they provide, having to have the discussions that they have to have. That is such an incredible responsibility that they have. And, they have a lot of compassion as they do these things and they feel these things, I'm sure, just along with their patients. You don't just become some robotic numb person that doesn't, do you know what I mean, that
Mhm.
doesn't feel the emotions of those around you. They have to deal with these things, and I can only imagine the stress that that puts on them. So that's why I say we have to have empathy, because in these situations you don't know what they dealt with coming out of a patient's room right before they came into that office to have this education session with you. And I think that could go for any specialty. You really don't know day to day what they've been dealing with. So empathy does go a long way, I feel. But
Well,
also,
and that's why it's important too to have this policy created
yes.
at the administrative level, because when there's back and forth, when there's disagreements, that needs to come from the different viewpoints.
Hmm.
To your point, don't include every single practitioner in that department. Their lead physician can be their voice. From the coder's perspective, don't
Yes.
include them in and put the burden on them. That should be coming from the management of that department and everybody working through the back and forth, the disagreements, the misunderstandings at the administrative level, having a policy to fall back on
Mhm.
and then taking it back to the group from there with the expectation that this is now effective, it will be followed, and
Mhm.
if needed, you have the backing from, different
Yeah.
administrative people.
And deal with behavioral issues outside outside of that. Um,
Exactly.
because
Exactly.
compliance isn't necessarily about behavior.
Yeah.
It's it's not compliance isn't optional. I mean, there's really no way around it. You don't have any other option but to be compliant, and you have to be able to separate those issues from each other and have buy-in from the appropriate people to enforce compliance and make sure that there is accountability when providers are not doing what they need to do to ensure that there's compliant billing of their services.
Mhm. Very well said. And I know that I've been mentioning this a lot lately, but I'll end it by saying, this is why it's so important to have external audits.
Mhm.
I through my firm, this is something that I believe very strongly in when I work with my clients. We have to make sure that you understand what you could come up against in an external review. So when we find these issues, it needs to be taken seriously. Hopefully, you would want to address it this way, because if you're not doing this internally and dealing with the issues internally, you could have to look at it from the defense perspective, which is a lot more costly, and
Mhm.
additional things are built in. So really, at the end of the day, it's important to have a policy. You need to continue to be a strong voice, even if you feel you're not being heard, and
Mhm.
then go from there. If somebody higher up is ignoring, look to who else would be involved that you need to communicate with. At the very least, if you're still not being listened to and you're being told to push it out, hold it somewhere and say you're waiting for answers. You want it in
Yes.
writing, you want the sources to back up the direction you're being given,
Mhm.
and hopefully that'll be worked through.
Yeah.
All right. Now, remember to visit the website, stephanieallardconsulting.com. I do actually have a discount that is going right now on the membership. You can get 20% off. There's no discount code needed, it's automatically applied. It is for both the monthly and the annual membership. That does give you access to ask the expert or the auditor, which is myself. So you can submit questions throughout the month, and I have a response for you within 24 hours to help you, whether it's a practice and you're dealing with that, or an individual person and you want that resource for yourself individually. Hit me up there. We do also have a lot of articles, on demand resources, audit tools, webinars, things like that. In addition to that, I wanted to announce next week I'll have a special guest on the podcast. So we're going to have Terry Fletcher from Terry Fletcher Consulting join, and we're going to dive into the beginning of a new series around compliance and what that looks like for your organization. And really, jumping off from what we just talked about at the end of this episode, how do you go back? How do you implement things that, are needed, and the reasons behind that, and what to do when you have pushback, all of those things. So have a great week and hope to see you back next week.